Other slide.
We might as well keep joining. The numbers are going up quickly. We can highlight the talk tomorrow by Grace Chan about advancing child health in vulnerable populations. Grace has a huge amount of global health experience. And then a really interesting talk by really international superstar in causal inference and causal attribution on Friday the 15th. And then finally, see DBHi's talk on June 4th.
And just a note for anyone who did not notice, the visiting speaker on the 15th has unfortunately had to pivot to virtual. He's not able to make it in person any longer, but there are still opportunities to meet one-on-one with him virtually for anyone who's interested. So please reach out to me if you are, and I can get that set up.
Great. So let's jump in. We have more, we've already hit 80 participants. I think that's great, in addition to those of us who are here in the room. And if anyone is on campus and wants to come over, we're in 10105, which may not be that far away from some of you. So it's really my pleasure to introduce Dr. David Kaelber, who feels like an old friend at this point and a longtime colleague. He's a practicing internist and pediatrician, as well as the Chief Health Informatics Officer of the Cleveland Metro Health System, which is a safety net health system in Cleveland. And David's been really a key architect of getting that system involved in impactful research on a national and even broader scale. David's also a professor of internal medicine, pediatrics, and population and quantitative health science at Case Western. He leads the biostatistics, informatics, and data science core of the Northern Ohio CTSA, and is a fellowship program director for Case Western's Clinical Informatics Fellowship Program, which is the largest clinical informatics fellowship program in the country, remarkably enough. David is here today, and primarily for this reason. He's been involved with Epic Cosmos and its predecessors for over 15 years, and was given the honor of being the first non-Epic employee to log into Cosmos. His talk today, Epic Cosmos, a paradigm-shifting tool for certain types of clinical research, can provide an overview and introduction to Epic Cosmos. And I think we also have someone here in David who can provide an incredibly rich context for what has and maybe hasn't worked as well in Cosmos and where the opportunities are. So Bob, I'll turn it over to you.
Thank you. Yes, I was looking back to try to remember when I first really became aware of Dr. Kaelber, and I think it was at a Epic user group meeting sometime around the time of his 2007 JAMA article, where he used Epic data to document the rate of underdiagnosis of high blood pressure in the context of pediatrics. And I still remember him in the bow tie, shown in the picture here, standing at the front of the room, talking about that piece of science he did. And I was very early in my own journey as a researcher, and it really had a big impact on my own career and enthusiasm for reuse of electronic health record data for purposes of scientific discovery. And actually, as Alex also alluded to, David can correct me if I'm wrong, but I really view him as the creator and instigator of what ultimately became Epic Cosmos through some work that they had done in the context of Metro Health. And I really credit him with developing the slicer-dicer sort of user interface, which I think is really amongst the first and the best tools that allows people to have self-service access to data that is both meaningful and does not require knowledge of SQL. So with that, by way of my introduction added to Alex's, I'd like to warmly welcome Dr. Kaelber, and I'll turn it over to you for your talk.
And if you arrived late, the CME information is in the chat. Thanks, David.
Wow, well, thank you both very much for that very generous introductions. Yeah, I think it's been a while that I've been working with both of you. It's been wonderful relationships. Really appreciate the opportunity this afternoon to talk to you some about my Cosmos journey. Yeah, I mean, I was the first person to be given non-Epic customer or non-Epic employee to be given a login and password. I guess I don't want to take too much credit for the development of Cosmos, just from the standpoint of, it's an Epic tool really developed by the Epic Corporation. The one quick little story I will give is when I was at the Epic Research Advisory Council back in spring of 2009, Nancy Smiter, who Bob, you may know, Alex, you may know, they were asking for any big ideas that people had. And I had just led our implementation of Care Everywhere. So I wrote on my little card the word research everywhere. And then I was asked to explain what is research everywhere. I said, well, it's exactly like Care Everywhere, except instead of the purpose being for clinical care, it's for research. And I guess in fairness, and I think there were other confluencing factors at the time, but that Post-it card was one of the initial sparks that sort of led to what now we call Cosmos. But anybody that knows Judy Faulkner, she vetoed the idea of research everywhere as a word for right away. So obviously they went through other iterations. But anyway, so I have been involved for a very, very long time, but really the credit for the heavy lifting goes to the Epic Corporation. So I have my talk broken down into 6 different areas, really. So this will sort of be a whirlwind. I assume people in the audience are sort of at different levels of their Cosmos knowledge, of aggregate electronic health record data knowledge, SQL knowledge. So trying to sort of level set with lots of different audiences that I imagine are in the crowd. So I'll do a little bit introduction, framework overview, talk about some of the Cosmos powered tools in Epic, which I think is just important to understand some research opportunities even there, and development opportunities. Then really Cosmos for what I think most people are thinking about, the retrospective data research, delve a little bit into the difference between Cosmos Slicer Dicer and Cosmos Data Science, then talk about 5 examples that I've been involved in that have used Cosmos to try to put it all together, and then try to leave a little bit of time at the end for discussion, questions, those types of things. So learning objectives: to provide an overview of Epic Cosmos, 2, to explain the difference between Cosmos Slicer Dicer and Cosmos Data Scientist Virtual Machine, also called data science, to describe examples of research that has used Cosmos. And then again, I'm always very conscious of, I am taking up like an hour of your life. So hopefully for most of you, you will be able to do at least one thing new or different after this discussion. Otherwise, I have not fulfilled my job of making your hour with me valuable. Disclosures, I really don't have any disclosures relevant here. I have no financial relationship with the Epic Corporation or with Trinetics, another tool I use a lot. But a huge part of my professional career is based on my partnership and productivity with these companies. And I do serve as on voluntary leadership groups, both with Epic Cosmos. I'm on the Cosmos Governing Council, as well as I'm on a customer advisory board with Trinetics. Although again, in this talk, I won't really be talking about Trinetics. So, I mean, to me, and I guess, Bob, I appreciate you mentioning the underdiagnosis of hypertension, because that was the spark that really triggered me as well. I mean, I won't talk about it a lot here, but basically, I started to see isolated kids with undiagnosed pediatric hypertension. And then I said, wow, if I'm seeing a couple patients per day, or excuse me, per week in clinic, what if I did like a data pull? How big of an issue would this be? And of course, when I pulled all this data, and all this data at that time was like 15,000 patients, that seemed huge back then. I found that this is a really big issue, and my study, Underdiagnosis of Hypertension in Children and Adolescents, was actually cited as one of the top 10 breakthroughs in all of stroke and cardiovascular medicine in 2007, 2008 by the American Heart Association. So this just reinforced this belief that, wow, we're spending all this time entering data into the electronic health record, but wow, now that it's there, we can do amazing things. So this is the sort of idea, like data is power. And I think that has just magnified in the now almost 20 years since I did that original work. I like this cartoon. Let's solve this problem by using the big data none of us have any idea, the slightest idea what to do with. So I don't know if there's anybody in the room feeling like that. Hopefully, again, by the end, you will not feel as much like that, because what I hope to be showing you today is that the data and the tools and the processes exist so that for certain types of clinical research questions, we can use big data to answer those in profound ways. Why is now sort of the time for this? Again, I won't go back into a huge history lesson here, but to me, a huge catalyst for where we are today is the American Recovery and Reinvestment Act. The part of that was called meaningful use, which to some of us seemed like a dirty word, at least for in the mid 20 teens there. But what this did, passed in 2009, 2010 with the Great Recession, is over basically a 4 to 5 year period, it hugely catalyzed the adoption of electronic health records in the US, both in hospitals and in office-based practices, so that by the time we got to 2014, you can see we basically reached a plateau where pretty much all hospitals have electronic health records. Obviously, CHOP has them, Metro Health has them, and the overwhelming majority of office-based physicians do as well. So this then has allowed for the data foundation on which to build all of these tools like Cosmos. I think it also points to the idea, just to, again, probably obvious on some level, but what this means is that it's very hard to use these sorts of tools to investigate things where the data is before 2014, right? Because that even though there was data before 2014, Metro Health went live with Epic in 1999, but it means there's already something unusual about that data because most of the data was not in the electronic health records. We'll get back to that a little bit later. So what about Cosmos now? So we have this paradigm where all this data started being collected. We had the research anywhere. We had the underdiagnosis of pediatric hypertension. And so Epic, literally really since 2009, has had this vision of what would it mean if we could combine all of the data from Epic customers that was not collected for research, it was collected for clinical care. But what if we could combine that all into a single data source and then put some tools and user interface around that source so that it's accessible to people that wanted to use that data? So, at this point, this is called Epic Cosmos. So let's go through some of the basics here. So at this point, there are over 300 million unique patient records in Cosmos, about 125 million visits per year. The overwhelming majority of these patients are all US patients, but as you can see there are already patients from Canada, Saudi Arabia, Lebanon, and soon to be Switzerland as well. You can see 17 billion encounters, 21 million cancer cases, 13 million rare diseases. Again, particularly think of pediatrics. Even a disease that happens 1 in a million times, right? If you have 300 million patients, statistically that will be represented 300 times. So huge opportunities, I think, for rare diseases, which again are particularly poignant in the pediatric population. You see 1,600 hospitals and 38,000 clinics. So just giving you some sense of the breadth of that data. What about the sources? So again, this is, I would say, at this point, even maybe a not totally complete list, but what is in that structured data? Right now, Cosmos basically just has structured data in it. There are some moves to go after unstructured data, but really what's usable today is the structured data. So what is that? So it's medications, it's labs, it's CPT codes. Again, for those of us in informatics, it's those typical UMLS ontologies. Epic is trying to go after some special things like mother-baby linkages, transplants, home and healthcare, cancer staging, insurance information, social drivers, genomic data, patient-reported outcomes. So lots of different things that are going into this, although Cosmos is only open to Epic customers, so that can be an advantage and a disadvantage. It means if it's not an Epic customer, then obviously the data is not going to be in Cosmos. But it also means then that you're not limited to the lowest common denominator, say, of UMLS, which is across all vendor electronic health records. And you can use some Epic data model specific data elements, which can be particularly of use in social determinants of health, which I'll touch on a little bit later as well. There's a governing council. I'm one of the people in the governing council there. Really encourage as you get into your Cosmos journey. I'm not exactly sure where you all are at CHOP, but there is someone from Penn Medicine on the team. I don't know the exact relationship there, but really encourage, the right people, maybe Bob, maybe Alex, think about joining the governing council. It really gives you an inside look into what's happening and then guidance on what you want the Epic Corporation to do and continue to move forward with Cosmos. This is just some sense of the use of Cosmos. So I'd say this is already a little bit outdated, but as of a couple months ago, there were almost 140 publications using Cosmos across the community in over 80 different journals. There has been a number of funded research using Cosmos through ARC, NIH, VA, CDC. We've had funded work through the CDC as well as NIH. So that gives an overview of sort of what Cosmos is and some of the foundational elements that allowed us to get to Cosmos. I did want to take a little bit, I wouldn't call it a detour, but just to make sure, I think people tend to think of Cosmos solely as, hey, let's look at the data in Cosmos for research, and that's great. But there are an increasing number of Cosmos-powered tools in Epic, which I think offer their own research opportunities for how well those tools work, and also speaks to the idea of the opportunity from a research perspective to partner with the Epic Corporation to actually build more Cosmos-powered tools in Epic. So what are some examples of that? So there's already a Cosmos sort of length of stay or remaining length of stay, based on similar patients to the patient that you have sitting in a bed to predict the median length of stay that similar patients have had to help with discharge planning. This would be one example. Another example, of course, pediatric example, really awesome. So, the CDC only has a certain number of growth charts, but because of the Cosmos data, even very rare diseases, there can be a number of patients to estimate the appropriate growth charts for patients with those specific conditions. So for instance, what I'm showing on the right here is girls with Rett syndrome. And as you can see, right, if you plotted this specific girl's growth chart on the normal CDC growth chart, it looks like they're very undergrowing. In this case, based on their height. But when you use a disease-specific growth chart powered by Cosmos, you get a much different understanding of what the growth of that patient actually looks like. So this is another thing probably available in your systems today, or could be available powered by Cosmos. Patient-reported outcomes after surgery. So again, this is the ability for, if you're doing patient-reported outcomes, you can see how your patient-reported outcomes for an individual patient or population of patients compared to the equivalent patients for the same surgery, their outcomes reported through Cosmos. So this is another one that I don't know which version of Epic you're on, but is available in the February 2025 version of Epic. Connect with providers treating similar patients. So this is called it's also called lookalikes. So again, particularly for a referral children's hospital, I'm not sure if you've turned on this feature. We've turned it on at Metro. And it's just this idea that if you have a patient that seems to be, a medical mystery or ultra rare conditions, you can see not the protected health information, but you can see the institutions and the providers that have had similar types of patients, with the idea that then you may want to reach out to those providers at those other institutions for sort of counsel and support in taking care of the patient that you're involved in. Again, powered by Cosmos. Best care choices for my patients. Again, I think this is, a lot of us think this is amazing and super scary at the same time. So far, this is really only available for adult patients, but it's this idea that instead of looking at research which is done just on a small subset of patients, in this example, we can look at a particular patient, adult patient with hypertension, And if we're trying to potentially change or add another medicine, we can see for patients very, very much like this specific patient, when they have had other medicines added to them, what has that done to the blood pressure control and other outcomes of interest? So it's a whole new data source that we could potentially rely on to trying to make best care choices, or at least care choices for a patient in front of us, besides just relying on published research on specialized populations in a research setting. Again, powered by Cosmos. Cosmos antibiograms. I'm very excited about this. We should be getting this one later this month when we upgrade to November 2025 version of Epic. So this is this idea of a community antibiogram, right? So probably all of us at our own institutions do our own institution-specific antibiogram, but this is the idea of, in Cleveland here, we have Metro Health is on Epic, contributing to Cosmos, so is University Hospitals of Cleveland and Cleveland Clinic. So we can have a community antibiogram all created through contributions through Cosmos at the county level. Much more robust information. And then again, usually our antibiograms are about 6 to 12 months behind. Why? Because it takes the team that long to curate our own data, where this would be much more real time. A diagnosis checker, again, something else powered by Cosmos that should be available now to folks in Cosmos, is be in Cosmos, where if you have a patient with a certain series of symptoms, you can type this into sort of like this AI type agent, and it will tell you what are other symptoms that similar patients had, particularly if you're trying to come up with a diagnosis or other things to look for in the patient in front of you. Again, another feature powered by Cosmos. One of the other ones I'm most excited about, and this one really has to do with the multi-center studies. I just gave a whole talk about this, so I'll try to be quick about this, but this is the idea of Cosmos Teleport. So this is that if you're trying to identify sites for a multi-center trial, you can do the query in Cosmos, right, among the 300 million people, then you can push pointers to patients at individual healthcare systems like CHOP, like Metro, and then it's easy if someone in that institution wants to see if they have enough people to participate in a multi-center trial. The query has already been done for them. They just have to identify if they have enough patients, and then of course they have to want to agree, that the institution has to want to agree to participate in the study, has to find a PI, those types of things. But this can really help with the idea of site selection. And then when you get down to patient selection, identify patients as well. And so it's not every, I know Bob has helped with this in the past, it's not every single Epic institution writing their own SQL or Clarity query to identify patients in their own system, right? That's all centrally done and then pushed down to participating sites to recruit individual patients. So again, the reason I mention these here is that these are, from my standpoint, all opportunities from a research perspective to either help develop these powered by Cosmos tools with the Epic Corporation from a research perspective, and or study the impact of these tools on clinical care. So for instance, we and a number of other sites have looked at that best care choices example and sort of tried to figure out how does that improve the care of patients with hypertension. Okay, so now I'll get more into Cosmos specifically for research. So in order to do this, I want to try to provide you with resources and sort of some level setting. So this will be one chance for audience participation. Does anybody know who Thomas Watson was?
No, James. That's right.
I don't know if there's anything in the chat. So the most common answer I get is, wait, was that the Watson of Watson and Crick that created DNA, or discovered DNA? No, this Watson is the founder of IBM, right? So think the Watson machine that won Jeopardy, right? So this is that Watson. And I love this quote from him: the ability to ask the right question is more than half the battle to finding the answer. And so to me, one of the keys is don't go to a tool like Cosmos with this amazing research question and then be sort of frustrated that you don't have the right data, the tool doesn't work, all those sort of problems. What you really want to do if you want to really leverage a tool like Cosmos is you want to understand the types of questions and the types of data that Cosmos has. And then within your field of research, ask a question that's going to maximize the opportunity of Cosmos and not sort of run into, any of the challenges that Cosmos might have. Because I'm the first to say, there's a whole bunch of scientifically important questions that a tool like Cosmos in 2026 is not going to be able to answer. Having said that, I would also say that there's a whole bunch of scientifically important questions that a tool like Cosmos can answer today. And then part of the key is most of those questions have not been answered using Cosmos today. So there's a lot of low-hanging fruit here. But again, it's not every question that you have is going to be able to be answered by Cosmos. So the ability to answer the right question is very, very important when using a tool like Cosmos. What tools do we have, or what resources can I help point you to? So there's a bunch of articles I'll just mention to you. This is what I worked on with a number of different folks using electronic health record enabled research for children, using electronic health records for clinical discovery. So feel free to peruse this. This is specifically geared to thinking about some of the pediatric issues in using electronic health records. That's one. Another one we just came out with a couple years ago was with big data comes big responsibility. Strategies for utilizing aggregated, standardized, de-identified electronic health records for research. So this really covers 26 topic areas to consider when using aggregated, de-identified electronic health record platforms like Trinetics. Another one that I didn't have anything to do with is one that appeared in JAMA last fall called the target statement. This is specifically around the subset of studies that you might do using a tool like Trinetics. That would be what is being called target trial emulation studies, retrospective emulation studies. So that's sort of where you take two retrospective cohorts, one that got an intervention, one that didn't get an intervention, and you're trying to project over time what the difference in outcome between the two groups are from the retrospective data. So this is sort of a subset of when you would use something like Cosmos. But again, I think a very important subset. So a lot of people are thinking about some of the methods and some of the techniques and some of the pitfalls of using these sort of tools for that. So give you some of these research references. And then Cosmos specific, and I think these two were actually sent out as part of the materials for this talk. So I was involved in the first ever Cosmos publication that came out in 2021 in ACI Open. And what we do in this publication was we just review at a high level what Cosmos is. And then basically these examples, we reproduced other published studies using different methodologies, looking at obesity and asthma, seasonal influenza and coronavirus, HPV vaccination adherence, MMR and febrile seizures, and antibiotic usage for upper respiratory infections, just to show basically that we could get the equivalent results as these sort of studies that were done using different methodologies. But of course, the power of our studies and the efficiency, the speed, the limited resources which we were able to do these studies was much, 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 much greater because of the Cosmos tool. So again, you can use that if you'd like. And then just like literally hot off the press, it was finally published just about a week or so ago, was an updated Cosmos overview publication. We called it Advancing Real World Evidence Generation, Growth and Lessons Learned from the Early Years of Cosmos. So basically describing the development and use of Cosmos over its first 5 years, basically from 2020, 2021 to 2025, 2026. So I would say these two are, if you don't know much about Cosmos yet, these two papers that I just referenced will sort of get you up to speed pretty quickly. So some of the power of Cosmos, I mean, the vision here has been to create the largest repository of patient data in the world. I think it's achieved that. I don't know a larger repository of clinical patient data. It does, participants contribute a limited data set. Then they get access to improve patient care and to better understand health and disease. I think we talked about this before. Metro was the first to sign up in January of 2018. We were the first to contribute data later that summer, and then we logged on just before the pandemic in January of 2020. I like to show this. This is just a smattering of some of the healthcare systems that are participating in Cosmos. And to me, the reason I show this slide is because of the diversity of healthcare systems contributing. So just as an example, in the middle there, you see Cape Cod Health. I'll be honest, like I'd never heard of Cape Cod Health. I'm sure they're a fine, medical center. They're probably not an academic medical center. Beaver Medical Group, Fast Med Urgent Care, right? I mean, to me, these are not your traditional academic medical centers like, University of Chicago is, University Health System. And so to me, one of the huge opportunities here is many research studies are done at academic medical centers like Metro Health, like CHOP, and that's great. But we get the sense then that we're cherry picking the patients, right? So the patients that come to our healthcare systems might not be representative of patients who don't come to our academic medical centers. And I think Cosmos goes a long way to help with that because, yes, it includes data from academic medical centers, but it includes data on patients from a lot of non-academic medical centers as well. Okay, so we got that. I'd say no, I can't be an informaticist worth my salt unless I have one schematic diagram of sort of how Cosmos is set up. So this is sort of that picture. I won't go into it a ton, but I think it's worth describing a little bit. So, on the left-hand side, you have the participating healthcare system. And at this point, there are, literally over 300 of them. And so there is ongoing submission triggers. So literally, this all uses Care Everywhere as its backbone. So, I mean, literally, during this talk, there's probably been a couple hundred new continuity of care documents from Metro that have been sent to Epic for our Cosmos patients. Literally every minute, every second, as encounters are closed, new things happening, these continuity of care documents, CCDs, are being sent. There's also a backloading process. So, we went live in 2020, but all of our data was backloaded back to 1999. And then it really goes through a, querying process and it goes through a secure web services in a limited data set form. And so we'll get into this a little bit with HIPAA. So there is limited data set. This is one of the early design decisions we made. So what makes it limited data? So we do send address. Basically that, it's not de-identified, and we do send dates, dates of visits, dates of procedures, birthdays. So that's what makes it limited data set when it's being sent to Cosmos and not de-identified. But then on the Cosmos side, it does go through a de-identification. Well, first of all, it goes through a deduplication process, leveraging the same technology as Cosmos, as Care Everywhere. And then it also goes through a de-identification process. Now, again, if anybody's familiar with HIPAA, there's two ways for something to be de-identified, right? One is safe harbor, which means you can't include any of those 17, 18 elements. So this would not qualify under safe harbor because I just told you that there are dates and addresses. So the methodology that Cosmos uses expert attestation for de-identification. So that's, you find the expert who knows what they're doing. They talk to you about how you can make your data de-identified, still starting from a limited data set. And again, we'll touch on that a little bit more. All this is sort of put into a massive server bank hosted by the Epic Corporation, and then people log in through a web portal. And there are basically two pathways for that. Sort of everybody can use the all user access. And then there's sort of special access to more sophisticated tools, which we'll talk about through the data science trained users. The growth of Cosmos has been a very steep linear curve. So, the patients basically over the last 4 years or so grew from about 10 million to about 300 million. And the organizations grew from 0 to, over 300. So you can sort of see what that looks like. There are some specific things, and again, I won't go through all the details here, but again, there's just a bunch of and the reason I point out some of these examples is you just, if you're going to use these tools, you got to invest in some of the gotchas. So this isn't really a pediatric example, but I think it's illustrative. So here I'm looking at the Metro Health slicer dicer and seeing, look at this. At Metro, we have over 21,000 people that are, basically alive and more than 110 years old. That's incredible. Like, we must have the Guinness Book of World Record there. Do you believe this figure? And the answer should be, you should not believe that figure. I mean, that's what the data shows. But the challenge here is that unless you die in the hospital, the EHR might not know that you're dead. So there could be a person that was, in 2005, right? They were 80 years old. They were being seen at Metro. Then they moved to Florida. Then they died when they were 90. But, they, in our system, they still look like they're alive because there's no robust mechanism for us to be notified that they were dead. Now, hopefully, we're not dealing with too much death in the pediatric population, but these are just some of the things to think about with electronic health record data. I mentioned this before. One of the great things about, from my standpoint, about Cosmos, because it leverages the proprietary Epic data model, is most sites, and I understand CHOP is doing this too, uses these discrete social drivers of health. So this can really leverage a lot of data that you're not going to get from a non-Epic electronic health record. So at this point, there are tens of millions of patients of the 300 million that have self-reported social drivers of health. Epic also does things to impute various indices. So imputed, integrated in with Cosmos, is the US Area Deprivation Index, the US Childhood Opportunity Index, as well as the US Social Vulnerability Index, which, depending on what you're trying to do, may be of use to you. We've actually started to do some very interesting studies on looking at how the imputed data compares to the self-reported data, right? And the reason we're able to impute that data well is because, remember, one of the data elements that we uploaded was the address of the person. So behind the scenes, because all of these indices usually go down to sort of census block or census tract, the patient, but it's still imputed data at that geographic level. Okay, so we got that. I did want to point out one thing about funding, which I think is important if you're thinking about using Cosmos for research. So I sort of have these three buckets here. So again, our experience is, on the left-hand side, and we've done some of these studies with Dr. Pix and Dr. Grunemeyer. So it's relatively easy, I think, to get external funding for EHR interventions because they take significant resources, first of all, and they actually improve care. Our experience is that it's very hard to get external funding for real-world data studies, for instance, studies that solely use Cosmos, because they actually don't require significant resources, and they also do not directly improve studying what's happening, not intervening. So I'd say our most successful, when we've tried to get external funding, that's why I sort of have that comment, think about specific aim to be, right? So that's the idea of the main part of your grant is about something else, probably some sort of intervention, but then you're putting a Cosmos component into that because you're trying to see either how generalizable your solution might be, or trying to describe the scope of the problem, at a national level or a level that only Cosmos can describe. Then on the right-hand side, just a comment for people that don't know, if your institution is contributing data to Cosmos and you do not have any external funding, then Cosmos use is free. If you do have external funding, then there is a charge. So if you're planning to use Cosmos in a grant application, you need to reach out, before you submit the grant to understand what the Cosmos cost associated with the grant would be. Okay, now we'll move on just a couple slides about Cosmos Slicer Dicer versus Cosmos Data Science. So, and this is just a picture of what the two screens look like. So on the left-hand side, we have Cosmos Slicer Dicer, or SD, which again, I'm assuming at CHOP, many of you have access to Slicer Dicer within your own Epic environment. So it's basically the exact same user interface. It's just that instead of your own, I mean, in Metro, we have 1.7 million patients. Instead of your own, you're looking at the 300 million people. Versus on the right-hand side is Cosmos Data Science, or DS. And what I'm trying to show there is this is where you're actually logging into a virtual machine hosted by the Epic Corporation. And then that gives you the playground to do your SQL pulling, if you have those skills. Now, the model for all of this, which again, I think for some people is a paradigm shift, the model with Epic Cosmos is bring the people to the data, not the data to the people, right? So there's no concept of, oh, I just want to download, a comma separated variable, data set from Cosmos. That does not exist. You have to go to the data. The data does not come to you. Just to give an overview of these, so Epic Cosmos Slicer Dicer. Again, not sure how many people already use your own Slicer Dicer, but here you can see just the age distribution. So again, for those of us interested in peds, even from less than 18, there's already over 50 million patients represented in Cosmos. There are lots of different data models, which I have there under item number 2. The most common data model that people use is the patients one, number F. But there's some very interesting data models. So for instance, the organ transplant episodes data model. And then again, thinking of pediatrics, the patients with birthing parent information. So this is like the mother-baby linking. There are millions and millions of patients where you have both information about the child and about the birthing parent, sort of the biological mother. And I would just say our maternal fetal group has really leveraged this because we think by far this is the biggest data set in the world that has that, sort of baby mother linkage. You can look at data through bar graphs, line graphs, tree maps, donut graphs, pie charts, geomapping down to zip codes, and sometimes even below tables, cross tabs. So compare that to the Cosmos data science. So what's included there? So you're logging into a machine, a powerful machine with 2.7 gigahertz, 8-core CPU with 32 gigabytes of RAM is sort of the default setup. Provides direct SQL connections to Cosmos. You can work in RStudio with R, Jupyter Notebook, Python, SQL. Each project can have up to 20 gigabytes. There's collaboration and code management tools through the local installation of Git and a GitLab server. Epic maintains the latest libraries of Python and R, and it just gives you some of the details of the different types of analyses you can do based on the tools that Epic provides for you in that virtual environment. So now let's do some comparison here. So let's compare Slicer Dicer SD to Data Science DS. So what about the interface? So for Slicer Dicer, it looks just like your local Slicer Dicer. And so if you have people that use the local Slicer Dicer, that's an easy transition. In fact, usually the first asterisk there, our entry-level question to give Cosmos Slicer Dicer access to someone is, have you tried your query already in the Metro Health Slicer Dicer? If the answer is no, then we say try it there first, and then come back to us if either, one, you find that there's not enough patients to do your study just looking at Metro Health Slicer Dicer, or you found an interesting finding, but you're really asking the question, is this finding reproducible in a much larger population? Now going back up to the top, so then the interface for data science is a virtual machine, which is a very, very, very different type of experience. So what about Epic training and certification? For Slicer Dicer, it's really optional. Some local sites require some sort of training, but for the data science machine, it's required. You have to take a course by the Epic Corporation, be certified. Deep knowledge of the Epic data model. If you're using Slicer Dicer, I'd say it's not needed. If you're using data science, it is needed. You have to find the variables you want to. among the thousands and thousands of variables once you get into that virtual machine that you would be doing, you're writing a script to obtain. Analytic skills and experience, you guys say with Slicer Dicer, not really needed. With data science, very, very much needed. Data analytic tools in Slicer Dicer are relatively limited. You can mostly get counts, and everything else you really have to do outside of Cosmos. You have to take your data counts and take it outside. Obviously, with the data science, because it's got the R, Python, there's extensive analytic tools, and then access to expert-determined HIPAA de-identified data. It's yes for both. Just recognize, though, that even though both data science and Slicer Dicer have access to expert-determined HIPAA de-identified data, the expert determinations are different because of what you can do with the different tools. So you got to be conscious of that. It's not the same data that you're actually looking at. So for example, in Slicer Dicer, you can get down to zip code level analysis, but in data science, you can only get down to state analysis. I think somebody had raised their hand.
Yeah, Gerard, did
Hey,
you have
sorry
a
about that.
question?
I was trying to get off mute. Yeah, thank you. I had a quick question. So I use Cosmos's distant cousin, Oracle Learning Health Network, that's powered by Cerner, and specifically looking at individuals with sickle cell disease, and looking at mortality. And as you mentioned earlier, mortality seems to be like one of the big issues with a system like this, because if individuals die outside the hospital, they're often not captured. And we were able to use a third-party entity to like update those mortality tables. And I've had a number of meetings with Epic to try to figure out how we could go about doing this with Cosmos. And my question was, since you kind of was showing us in the back end that there were some tables that were able to be imputed from the outside at the limited data set level, if this was actually possible to be able to achieve.
Well, yeah, I guess I'll try to answer the question quickly. I mean, so probably you're talking about like Social Security Death Index. You probably ran to some vendor that's sort of leveraging that. So, I think part of the challenge is, Cosmos does not have the Social Security number, and the limited data set certainly does not include the Social Security number. And so what Epic is trying to do is they're, say, mostly trying to encourage local sites to do that. So I don't know if you just heard this, but even with Care Everywhere now, you can pass death information from one healthcare system to another. So I would say, again, from my standpoint, I mean, Epic understands this issue. Again, I don't understand all the details of the Oracle Cerner piece, but I don't think the model that Oracle Cerner used is going to be usable in Cosmos, but they're looking at other approaches to that. Okay, just to give people a sense, so at Metro Health now, again, we've been live about 6 years. We have about 80 Cosmos Slicer Dicer users and about 8 Cosmos data scientists or data science users. And so far, Metro has published 7 studies related to Cosmos. 6 of them have actually used Slicer Dicer. Only 1 of them has used data science. So I try to give that data to say, the data science part of Cosmos is much, much more powerful, but it's a much, 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 much heavier lift in terms of who is going to be able to use it and the time it takes to do science versus Slicer Dicer. So to me, it gets back a little bit to the Mr. Watson of, you got to learn about the tool and figure out, which part Slicer Dicer or data science is going to be able to be usable to answer your question. And then if it really says data science, do you have yourself or on your team the right people to be able to leverage data science, or do you really need to sort of reframe the question so that it can be answered using Slicer Dicer? Okay, let me, in the next 5 minutes, try to go through these 5 examples quickly, and then we'll end, hopefully have 5 minutes to show for questions. So to try to, there's a ton of stuff that went into this slide, 10 years worth of work, but to me, one of the things that people ask me a lot is, what are the types of questions that are going to be easy to answer in something like Cosmos, and really Cosmos Slicer Dicer. So I won't go into a ton, but these 5 seem to sort of be the sweet spot. So simple associations, I give citations for all these if you want to look, healthcare utilization, guideline compliance, descriptive studies in large or small population, and population health, chronic disease surveillance. Again, probably not going back more than about 10 years because that's where the, sort of the meaningful use EHR data sort of drops off the cliff, and probably more outpatient related studies. And why do I say outpatients? Because the density of data right now in the inpatient setting or even the ED is usually more than sort of can be easily teased out in Cosmos. And a lot of times, a lot of the data is in flow sheet rows and things that don't even get to Cosmos. So anyway, so this slide, a lot of people find is really, really important to help them frame the types of questions that they're going to be able to answer, that low-hanging fruit using something like Cosmos. So what have we done? What are some examples? So this is our first example. And I love this example. I don't imagine that Jane Hinkle is actually on this call, but I worked with her a case, and she is now a first-year MedPeds resident at the UPenn CHOP system. So she's percolating closer to you all than she is to me right now. But early on in the pandemic, we were looking at COVID and COVID-19 vaccines and myocarditis, sort of a simple association example. Again, won't spend a ton of time going to the results, but basically the general idea here was that, yes, you should be vaccinated because there's a small chance that you could get myocarditis from the vaccine, but there's a much bigger chance you get myocarditis from the virus. And this was presented at the AAP NCE in 2021 and won the outstanding oral poster presentation. Here's another study I did with a medical school student on firearms, fire injuries, and state gun laws. Again, a simple association. The really awesome thing here is trying to show how you can load external data into Cosmos. So there was another group that developed a scale by state of restrictiveness of gun laws. So all we did is import at the state level restrictiveness of gun laws, and then match that in Cosmos with ED visits for firearm injuries. And okay, hold on to your socks. Believe it or not, the more restricted the gun laws, the lower the ED visits for firearm injuries. My God, whoever would have thought that? It's true. But you could probably have never done this in anything besides Cosmos, because you wouldn't have that data. You wouldn't be able to put it all together. So this is just this idea to think about how you can look at Cosmos slicer dicer geographic data down to zip code level. I assume you all know this, but in your own slicer dicer, you can configure it to go down to census tract or census block. So I think this is one of those hidden features in Cosmos that can be super powerful for certain types of research. We're starting to leverage Cosmos for regional quality improvements efforts. It used to be that we would try to pull data from Cleveland Clinic, Metro, and UH. We couldn't deduplicate it. Very hard to pull it all together. Patients are seen at multiple healthcare systems. About a year ago, we decided just to use Cosmos for this because we recognize that 83% of the population, Cuyahoga County, which is where we are in Cleveland, is already deduplicated and searchable in Epic Cosmos Slicer Dicer down to the zip code level. So now you can see that graph in the upper right where we're just measuring our community-wide lead screening, percent of children tested by the second birthday through Cosmos, and everybody's working on quality improvement. And we're seeing that, basically 7%, over the last year or so, we've been able to improve the lead screening rate throughout our community. And we've turned it from measurement being its own project as part of this quality improvement to measurement being easily. This one person who I think Dr. Fix and Dr. Grunemeyer know, Matt Tien just goes in once a month and spends 5 minutes, updating the Cosmos query for the next month's worth of data. And the real work can be spent on actually improving lead screening. I mean, we just submitted this as an AAP NCE abstract, so hopefully we'll be presenting in November. Here's another one we published in Journal of General Internal Medicine, looking at COVID-19 and Paxlovid use, healthcare utilization. Again, the full reference is there, but basically what you're seeing, though, is that even though the rates of COVID-19 were similar, sort of regardless of race, ethnicity. What was happening as Paxlovid became more available, unfortunately, if you were white, you're much, 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 much more likely to get a prescription of Paxlovid than if you weren't white. So again, that's sort of that simple example of healthcare utilization. Guideline compliance. So I did this with one of my informatics fellows. We just looked at obesity diagnoses and guideline-based testing. Again, all based on guidelines that are well established by the AAP and then on the adult side as well. So I just highlight two of the high-level findings. So for people with a BMI consistent with obesity, did they have a diagnosis of obesity? So what you can see there, in adults, only 38% of the time did we actually put the ICD code in. In kids, over 50%, 52% of the time, we put in the ICD code. But then in terms of the metabolic syndrome labs to be performed, which should be performed on everybody with a diagnosis of obesity, that's where then the people without all the labs, that's where the adults providers did better than peds. So on the adult side, only 36% of the people did not have the testing. On the pediatric side, 60% of the people really didn't have any of that recommended testing. But again, guideline compliance, really easy type of thing to do in Cosmos. I always love guideline studies because there's no null hypothesis, right? Everybody hopes guidelines are followed 100% of the time. I have yet to run into a guideline that's followed 100% of the time. And people want to know, is it 80%, 60%? Are there patient or comorbidities that impact the compliance? And I'll just, I showed this slide again because it seems to be so important for people. Encourage you as you move in your Cosmos journey to have a Cosmos Datathon. We've had 2 already. We'd be happy to advise you on hosting yours. Or if any of you want to drive from Philadelphia to Cleveland, we plan on hosting our 3rd in the fall. For the sake of time, I won't spend really any more time talking about Cosmos Curiosity, but this is one of these LLM things on top of Cosmos. There's a really nice paper out of Yale that I referenced there. And then, so my last slide. So next steps, hopefully you now have a better sense of what you can do with Cosmos regarding big data after this talk. And it's not that you don't have an idea. Remember, Mr. Watson, the right question is so key to leveraging something like Cosmos. Think about whether Cosmos Slicer Dicer and or Cosmos Data Science will be better for you, your lab's needs, experience, resources. Remember the 5 ideal real-world EHR study types, at least as a place to start using Cosmos. And then what are you going to do differently after spending this hour with me? And my informatics team, we're always looking to partner with others. Cosmos is great because we're all using the exact same Cosmos throughout the world. And we already have a long history of partnering with people at CHOP, and we would love to continue that history. Thank you very much.
I guess we have about 1 minute. If anyone has any questions, maybe 1 or 2.
Yeah, I'm happy to stay after, but I know other people probably have things to do.
Lizzie Deemer, go ahead.
Hi. So you mentioned target trial emulation, but target trial emulation in large EHR data often requires computational power that would exceed the amount of RAM that you mentioned is available to researchers. Are there ways to access more like computational resources, or is that like a hard limit?
Yeah, so just really briefly, so I'd say we have not run into terrible performance issues, but actually it was announced at XGM last week where Epic does have a tiered system now. So if you're willing to pay more, they will give you sort of more space, more resources. So that model is coming out. So you may be able to do it with just the resources that you're given, or if that's not enough, they do have a sort of a pay for more resources model.
Thank you.
That's great. And Lizzie is highlighting our expertise here in growing in target trial emulation. So thanks, Lizzie. And Jeff Kaelber, jump in.
Hi, David. Great talk. Good to see you. Because you can't validate charts within this because it's a de-identified data set, are there any approaches that Epic or Cosmos is thinking of to try to permit at least kind of local linkage and validation, maybe at a couple centers to try to make sure that the exposures and phenotypes or outcomes are legit?
Yeah, so I mean, I could give a whole talk on this, so I'll try to be brief. So yeah, so first of all, a lot of people consider these sort of things more hypothesis generating than hypothesis proving types of studies. So that's one thing. Anytime you're using these, you should not just be searching the data to find a p-value, right? You should always start with a real hypothesis that would and sort of expected outcomes. And then, and I've written about this in many of these papers that I've written, where you should have some sort of, I wouldn't call it data validation because I think that's too strong, but data corroborating process. So either other studies, we've definitely done things where, I mean, you could reproduce the study in your own data, right? And get IRB and go in and look at that. Some people, I mean, the other thing that the Epic Corporation, which is not exactly what we're talking about, but they use like red team, B team approach. So they actually have the same two teams try to answer the same question in Cosmos and see if they come up with the same answer. I mean, that's less about validating the data. It's more about, agreeing on the methodology, because usually you talk to two report writers, they'll come up with different ways, to try to do the same thing. They might both be right or okay, they might not be. So anyway, so that's sort of the quick overview. But yeah, I think that whole idea of you just can't take your results on face value. You've really got to dig deeper and have some sort of, data corroborating step is extremely important if you're going to use these tools.
Thanks, that's helpful.
All right, to respect everyone's time, we'll let people drop off. David, if you have a few extra minutes, we can leave it open for other questions.
I'm happy to stay on. Yep.
Stay on for a few more minutes, and we can continue the discussion maybe a little bit more if anyone's interested.
I'd like to jump in with a question. David, you've been fantastic in getting your trainees in. Oh, we have actually, I'm going to pause my question because we have Dr. Zemmel with a question.
Hello. Sorry, thank you for a great presentation. I am curious about the construction of growth charts, especially disease-specific growth charts, because growth charts are really sensitive to the data that goes into their construction. And so if you have a lot of, for example, kids who have malnutrition as a consequence of their disease process, then you're incorporating malnutrition into what you're kind of describing as normal growth. And so I'm wondering how the growth charts get vetted, and whether there's any description that goes along with it so that people can evaluate those kinds of things.
Yeah, so again, that's why I brought these things up. So my understanding is all of these are published, right? Usually what Epic does is they work with Epic customers, pediatricians. They go through what I have not been personally involved in them, but they go through what's considered a reasonable methodology. They publish that methodology so that people can evaluate that for themselves. But again, to me, this would be an example. I mean, it sounds like you might be someone with some expertise in this space. So why don't you go to the Epic Corporation, work with them on, developing some growth charts that haven't been developed. Or if you're concerned about some of the growth charts they have developed, talk to them about that, right? I mean, I think this is where, that's what I was trying to allude to, these powered by Cosmos tools. That's an area for research, right? And that's an area for scholarly activity. The opportunity is that Epic is sitting on a mountain of data.
Great. Okay.
So yeah,
as long as it's transparent how to do that, which I will learn. So
yeah, and they're just not blindly sort of taking everyone with an ICD code of a certain thing and putting them in a growth chart. But again, I'm not familiar with the methodology, but most of those should have a publication with them. I was working with one of the people who was working with them on that. And again, if you need help getting connected with people, feel free to send me an email. I'll try to connect you.
Great. Thank you.
Dr. Koppel, good to see you. I think you're muted.
You're muted, Russ.
Yeah. Yeah, you're still shown as muted. We see you.
Do you want to type the question in the chat, Ross? In the meantime, Bob can ask his question.
Oh, yeah, I was just interested, David, you've been so successful engaging your trainees. I don't know if you had any quick tips for those of us who are faculty working with fellows in various disciplines, including informatics, to quickly get people connected with research opportunities in Epic Cosmos within the scope of their training?
Well, in fairness, I mean, we do have one fellow now who's getting trained as data scientist. That's a very high level for people. I mean, I usually direct my fellows to, something in Slice or Dicer. And again, it's usually really easy. And again, usually what I tell people, a lot of times people come ask me like, what is your lab working on? What can I do to help with a project in your lab? And I sort of turned that around and said, no. What are you interested in working on, right? I want to help you and your lab be successful. And people, what are you talking about? My lab? Like, I'm a first-year fellow. I'm like a second-year medical school student. Well, the key is that these tools, you don't need a big lab. I mean, the lab could be, you could be the PI, right, as the fellow or the medical student or the resident. I mean, I could be one of your consultants, and maybe you need, if it's not a primary care thing, maybe we need like another clinical specialist, but you don't need the big team, right? And again, it's the Mr. Watson thing, right? The key is, if you have an area that you're interested in, then let's Mr. Watson you. Let's think about those 5 topic areas. And I always call it a Shark Tank model, right? A friendly Shark Tank model, right? So think of some ideas using your area and those 5 topics. Pitch 2 or 3 ideas. And so far, I've never gone more than 2 Shark Tanks with anybody, right? And by the end of that second Shark Tank, we're able to figure out something where, I mean, I don't know it's going to work out because it hasn't been done. That's research. But like, okay, this question is probably going to work. The data is going to be there. The tool can do that. So now go off and do the work. And usually going off and doing the work means like, spend a couple days on it, right? I mean, it's not going to take weeks or months or years to do it because the tool, I've already done the data collection. There's no IRB needed. So it's pretty quick if you have sort of the right milieu and framing it to the trainee, fellow, resident medical student the right way.
Yeah, that's great. And I like the framing, bringing them to the sort of the 5 domains or sort of categories of questions where Epic Cosmos is great. Looking for Ross's question.
It's
I see
any
about
information patient portal use.
Yes, there's a lot of information. Well, I don't know exactly where, but there's definitely information on patient portal use in Cosmos. So if you want to look at just general trends of like, who signed up, age, gender, race, ethnicity, diseases. Again, the model I would use a little bit is I don't know if you have access, but, go into the CHOP or the UPenn Slice or Dice, and you're going to see there's a bunch of MyChart stuff there as well. And so that's similar to what you would get in Cosmos, even Slice or Dice or Cosmos.
I have a quick question, David. I know you can hear us, David. But so
Yes.
Thanks for the presentation. And it's like seeing Cosmos is something like, why wasn't it here yesterday? It's like an amazing tool that I think we're there, but now we want more. And so, like, if you look at all the data that we have on the medical side, most of it's unstructured, labs, flowcharts, you mentioned, and notes and things like that. And there's also agentic AI tools and other things coming up. And a lot of people are building these tools outside of Epic. Do you know like what's the roadmap of Epic? And I'm not as familiar with the Epic roadmap. Like some of these tools on a new roadmap coming into Epic, like clinical notes and flowcharts and labs, genomic information, for example, to sort of pull things together, or even taking data from all of us. So like these large, big collaboration projects that are happening, enabling them to be available, as a one-stop shopping through Cosmos.
Yeah, so I'd say Epic's working on all of that. I guess first of all, they're not really interested in going, I mean, at least right now I'm going after external data, like all of us or something, but sort of more doing a better job of data in the underlying Epic systems. I think flow sheets are relatively easy because it's structured data. The problem is we all have different flow sheets, right? So not only does it have to be structured, but it has to be common data. Right. And so there's a lot of problems with flow sheets because even though they're structured, it's not common data elements. And right, that whole aggregation function, if you don't know you're starting with the same thing, can be extremely problematic. So I guess that's one comment. I mean, they are definitely looking at genomic data. Again, I think that's partly the challenge of, just there isn't a lot of genomic data being collected, right? Again, and this is not like you have a biobank, right? This would be collected as part of normal clinical care. There's not a ton of people having that but they're definitely working on that in terms of the notes. So yeah, we participated in a pilot with them like 2 years ago to go after notes. They're starting to ingest notes, but they're being extremely conservative about it. So right now, their approach is to look at the note. First, they had to come up with a whole process to de-identify the notes, which again, I don't know your familiarity, but de-identifying a note, can be challenging. But I think they've worked through that, or they think they've worked through that. And now what they're really looking at is sort of what I would call Cosmos notes power tools. And so one of the early things they're looking at is this idea of, well, can we mine the social history, right, to then basically create structured data that we could add to the social determinants of health wheel, right? So they're sort of going after, hopefully, very low-hanging, unstructured data use cases where they could easily, and put easily in quotes, but easily turn that into structured data. I think it's going to be years before there's some idea of like, oh, we've ingested all of the notes and all of the notes are available just for, anybody to query. But it's I would say it's on the Epic roadmap. Now I said that has like, if you're familiar with Epic, that probably has like 3 little future asterisks next to it. It's like future, 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 future. So like way, way off in the future.
Thank you.
Excellent. All right.
I think.
I don't, Ross's hand's still up, but I think that's not a new question.
There's a question, sorry, about regarding my lab reports. Oh, Ross went away. Not quite sure there's enough context without Ross able to verbalize what the question was.
Yeah.
Yeah, well.
Thank you, David.
Thank you.
That was amazing. We might bring you back for part 2 if you're willing at some time in the future to talk about things in more depth. But I think that there's so many people still on and so many people engaged just sort of highlights just how important this is to people. And it really does create a path to doing research in an environment of potentially less funding as well. And so great on all counts.
Yeah, very, very much appreciate the opportunity to talk. Happy to come back again, virtually or in person. And yeah, again, I also think about, are there opportunities for collaboration? Because again, at the end of the day, we're actually all logging into the exact same tool. So that, to me, on some level, that makes collaboration, it's a much easier thing if we can come up with the right, the right business proposition, for lack of a better term.
Wonderful.
So.
All right, thank you.
Thanks, David. Thanks, everyone, for joining today.
Bye-bye.
Take care.
Bye.
The meeting.